Hey, we are going to go ahead and get going. It's noon. Good afternoon, everybody. We're so happy that you could make it, and hopefully everyone is warm and safe at home on this lovely snowy day. I would like to welcome our panelists and thank them very much for attending this DBS webinar. The goal of today's webinar is really to help you understand what the different device makers offer in their product and how to help make selections when you're dealing with DBS. So I would like to thank Yagna Pathak for being here with Abbott, Merrick Gorley with Boston Scientific, and Meg Lambert with Medtronic. And also a special thanks to Dr. Matt Mian for being our host today and being our moderator. Just so everyone knows, this is going to be recorded. It will be on our YouTube channel once it's done. And if you have questions, I will be monitoring the chat box so you can type your questions in the chat. We hopefully will have time after to answer any questions. And with that, I will let Dr. Mian take it away. And if each of you want to just introduce who you are, who you're with again, and how long you've been in the DBS space, that would be great. Thank you.
Why don't we go ahead and have the panelists each introduce themselves. So Yagna from Abbott.
Yeah, absolutely. Thank you, Dr. Mian. Thank you, Jody, for the introduction and for hosting us. Really excited to be part of this webinar today and hoping to share more about what Abbott has to offer in terms of deep brain stimulation. As Jody mentioned, I am Yagna Pathak. I am leading DBS Medical Affairs here at Abbott. I've been with Abbott for about 6 years and was a postdoc in neurosurgery at Columbia right before that. And then before my postdoc, I was actually getting my PhD in biomedical engineering at Marquette University. I've been in the field of neuromodulation for almost 15 years now and have experience across several indications and technologies. Here at Abbott, I've had the opportunity to really lead a lot in terms of our digital health portfolio. We'll be talking a little bit about a lot of those features as well, specifically our virtual clinic technology, which I actually was the lead scientist for. So really excited to be here with my colleagues from Medtronic and Boston as well, and looking forward to this webinar with all of you. Thank you.
Thank you. And Meg from Medtronic, you want to introduce yourself, please?
Yes, hello everyone. I'm Meg Lambert. I'm with the Medtronic DBS team, and I have been in the DBS space for about 14 years. Prior to joining Medtronic 3 years ago, I ran one of the largest DBS programs in the country, and I personally have served over 1,200 DBS patients in my career. I'm a neuroscience nurse, and I'm very happy to be here today to share the features and benefits of the Medtronic DBS device.
Thank you. And lastly, we have Merrick from Boston Scientific.
Thank you, Dr. Mian, Jody, and everyone else for having me. My name is Merrick Gorley. I'm a fellow of DBS Science and Engineering at Boston Scientific on the development team. I've been with Boston for about 7 years, in the DBS space for about 12. I live in Atlanta. I've got a lovely wife, 2 kids, a very understanding wife because I travel quite a bit. My background is in biomedical engineering. I got my undergrad from Georgia Tech and Emory and my graduate degree at Johns Hopkins. One of my main jobs at Boston Scientific is kind of managing the image-guided programming portfolio that we'll talk a lot about today. So again, thank you for having me here, and I'm very excited to show you what we have to offer.
Okay, thank you to all 3 of you. What I'm going to do is go ahead and share my screen. So I wanted to start with just a quick overview of DBS before we jump into questions for the panelists. So just a little bit about me. I'm a movement disorder surgeon, among other things, here in Colorado. I've been here between 5 and 6 years. I do surgery primarily at Swedish. I'll make a quick plug for my website down here at the bottom that has a lot of information about movement disorders and surgery at the bottom that people can check out on their own time. But part of the reason I'm here today is I'm a high volume surgeon. I do about 160, 180 movement disorder surgeries a year, most of which are DBS. And I use all 3 of these systems. I think all 3 are excellent. But we're going to try to highlight some of the differences to help patients and their family members make decisions when they're thinking about this kind of surgery. So again, I'm going to start with hopefully about a 10 or so minute brief overview of DBS for Parkinson's. Why do we do this? What does it look like? Who do we think about the surgery for? What can a patient expect? And then we're going to turn it over to the panel, and I have a series of questions that I'm going to ask each of them to address and to show you their devices so patients and their families can get a sense of what these implants are that we're talking about and how they compare. And then during that time, if you can think of questions that you don't feel like we're addressing or that you hope that we get to, you can type them into the box. Jody is going to compile them. And at the end, if we have a few minutes, we're going to try to address some of those audience questions. Please don't put any kind of personally identifying or personal medical information in those questions, but we'll do our best to try to answer for the whole audience. So with that, I'm going to just start with a brief overview of Parkinson's. So this is a relatively common disorder. It affects about 1% of people over the age of 65. And then in the US, we think there's over 1 million people right now with the disease. We know it's due to a gradual loss of dopamine-producing cells in the brain. We actually don't know what causes these cells to disappear. There are different theories about that and probably different reasons from one patient to the next. But the loss of that dopamine affects different parts of the brain. Among those parts is something called the basal ganglia, and that results in many of the movement symptoms with which I suspect many of the attendees are all too familiar. If you look at a brain that's been sliced and stained, you can actually see the loss of these cells, these dopamine-producing cells, in particular in part of the brain called the substantia nigra. We obviously can't do that in a live human, a live patient, and so we have surrogates to try to look for the loss of those dopaminergic cells. One such example is the DAT scan that some of you might have heard about or even had yourselves. And a loss of dopamine, which is a neurotransmitter, in other words, a chemical that's used to signal between nerve cells, it results in a variety of symptoms, but the ones that tend to be prominent and that often lead to a diagnosis of Parkinson's disease are the movement symptoms. And I've listed some of the cardinal movement symptoms here. Certainly there are others, but bradykinesia or slowness of movement, rigidity or stiffness, of course, a tremor, and then often later in the disease, problems with gait or posture or balance. I want to make a distinction in Parkinson's disease between two states that someone can find themselves in during the course of a day, what we call the on and off states. So in an on state, kind of generally speaking, we think that the dopamine levels in the brain are a little bit higher. Movements are more smooth and fluid, less slow. You may not have much rigidity or tremor. And we contrast this with an off state where we think that probably dopamine levels are lower in the brain. Movements are slower. There may be more rigidity and or tremor. And so the goal of most of our therapies, whether it's medications or DBS, is to try to shift more of a patient's time to the left side of the screen, to on time during the day, so that you enjoy more of that time where you have relatively good movement function. And we know that as the disease progresses, that window of good function tends to become narrower and narrower when you take a dose of oral medication, usually carbidopa, levodopa, but of course there are other drugs as well. And so the response tends to change over time, where eventually people become fairly brittle. They can vacillate wildly between a place where their movements are pretty good and when their movements are very slow or tremulous, and patients will often overshoot and develop these movements, abnormal movements that we call dyskinesias, which kind of look like a writhing or dancing that are not within the control of the patient. And so really, again, the focus of all of our therapies, DBS included, is to try to shift people's time to be spent mostly in this blue zone where people are having a good therapeutic effect from medication, from DBS, and less time where they're above or below that threshold. And so this is one example of what are called motor complications that can develop over time in Parkinson's disease. So medications wearing off rapidly. Another one we've already mentioned, dyskinesias. As time goes on, there can also be other symptoms that may have responded initially to medications, but are no longer as responsive. Common examples are tremor and dystonia. And we know that these complications affect at least half of patients on average 4 to 6 years after starting medications for Parkinson's. Some patients are sooner, some patients are later, but this is the rough average. And it's historically been the development of one or more of these problems with medications that has prompted us to think about the possibility of surgery. And so nowadays, when DBS is a fairly mature therapy, it's been around for over 20 years, as you'll see. At big centers that treat lots of patients with Parkinson's, we generally try to consider DBS for Parkinson's patients who have developed one or more of those motor complications. DBS has been around for a long time. It was studied in the 1970s and 80s, perhaps even before then. And the idea is that targeted electrical pulses can be delivered to very particular parts of the brain to try to interrupt the abnormal rhythms that we know are associated with some of the movement symptoms of Parkinson's disease. This is kind of like a pacemaker. We're just applying it to the brain instead of to the heart. The advantages of this over some of the historical treatments for Parkinson's, surgical treatments, are that DBS is reversible. It can be removed if needed. That almost never happens, but it can be removed. It's flexible, meaning the stimulation can be changed dynamically for a patient as his or her symptoms and disease change over time. And it's not destructive of the brain, so it tends to have fewer side effects than some of those previous procedures did. DBS was approved first by the FDA in 1997 for essential tremor, a different disorder that we're not going to talk about today, and then just a few years later for Parkinson's, and there have been hundreds of thousands of implants since that time all across the world. At a big picture level, this is kind of what the system looks like. You have a wire that's going into the brain. I don't know if you guys can see my mouse, but the wire is just about 1 millimeter wide. It's pretty small. You have a wire that then travels under the scalp, usually behind the ear, and down to a little pacemaker that's attached under the collarbone, under the skin. This entire system is inside the body. Nothing is exposed or outside the body. And the system runs in the background 24/7 as you're engaged in your everyday day-to-day activities. This is showing an implant on one side of the brain. You can have one side of the brain treated. You can have both sides treated. One side of the brain contributes to function or symptoms on the opposite side of the body. So some patients need one side treated. Some patients need both sides. Just a sneak peek in terms of what this surgery looks like. There's lots of ways to do this. This is how I tend to do it. I use a surgical robot to assist me in placing the leads. I found that it's very accurate and efficient. Patients often think the robot does the surgery, but in fact, the robot never touches the patient. It's just a very precise aiming device. But there's lots of ways that surgeons can do this. This is what an implant looks like after it's placed. You can see the tiny wires in the brain. This is a patient that got both sides treated. And I think we got a little spinning video here on the other side just to give you a sense of and a 3D perspective what a wire looks like. So most importantly, before we get into the nuts and bolts of these different systems, does this system work? And what is it good for? What is it not good for? We are lucky in that we have more randomized controlled clinical trials for DBS, for Parkinson's, than for very few other things in neurosurgery. And among those studies, I've just highlighted a few here. One benefit of DBS that's been demonstrated time and again is that it improves patients' functional status, their ability to engage in everyday activities that are now rendered difficult by the disease. And we can see a big difference between a person's state on and off medications before surgery. That difference really shrinks over time with the device so that you don't see these wild fluctuations as much once you have a DBS system in place. Patients report an improvement in the number or an increase in the number of hours they have per day of good motor function. This big study described that the average patient saw an extra 4 to 5 hours per day of their best movement function. 4 to 5 hours per day, when you think about how much time we're awake and how much time we have good function already, that's a pretty meaningful difference to most patients. I don't think I have a slide for this, but most patients who get DBS are able to substantially reduce their medications, both in terms of the dose and the frequency, which is a major advantage. And then most importantly, big picture, patients who get the therapy report a better quality of life after surgery versus before. Frankly, this is the most important slide in my opinion. And this is across a variety of metrics applied to Parkinson's disease. So just to summarize, DBS helps improve functional status or independence for those with Parkinson's. It provides more good motor function time, again, what we call on time. It reduces the cardinal motor symptoms of Parkinson's, including tremor, slowness, rigidity, and dystonia. It helps with medication dosing, and most patients do see substantial reductions in their medications. And again, most importantly, it tends to improve quality of life. What do I tell patients in the office? I tell them that DBS is effective for movement symptoms, particularly those that respond to levodopa or Sinemet. It's not effective for non-movement symptoms, so things like sleep or sense of smell or constipation. We don't think of DBS as a therapy for those things. The one movement symptom I would say, or one or two symptoms I would say that are kind of exceptions to this, are tremor and dystonia. Most all of the time, we're able to treat those with DBS, even if a patient is struggling with medications for those. DBS is not a cure. We do not have a cure for Parkinson's in 2024. There's a lot of hope for things like gene therapy, but that is certainly nowhere near ready to use in patients. Parkinson's is still a progressive disease, and it will continue to progress. But patients with DBS can often expect, I tell patients that you can expect to see your symptom clock set back by 5 or so years, just in terms of how you feel. Again, DBS provides more of that good motor function time per day, but it usually doesn't make the quality of that time much different than it otherwise is with medications. So who are we thinking about DBS for? Generally speaking, it's patients who've had Parkinson's for several years, those who at least initially had a decent response to levodopa or Sinemet, and again, those who have developed some of those things that we refer to as motor complications. Okay, I think I had one more. Oh yeah, the greatest barrier, honestly, that we face, and what we're trying to change with webinars like this, is that most of the patients out there that would benefit from this, that would be candidates for this, do not learn about DBS, do not get referred to DBS, or unfortunately get referred too late. And so that's why we're using webinars like this to try to raise awareness of the therapy and educate patients about their options. I think this might be my last slide for now, but decisions for a patient who is considering DBS. We're going to focus on number 2 here, which device vendor seems the best fit for you. But other questions that patients commonly have to address in the decision process: do we treat one side of the brain? Do we treat both sides? Do we treat them at the same time or at different times? So that's a discussion for another day. Which device do you use, a rechargeable or non-rechargeable battery? And I think we're going to get into that a little bit today. But the basic idea is that all 3 of these vendors, all 3 of these companies offer devices that can either be put in and forgotten about and just changed after several years when the battery runs out, or patients can choose a rechargeable battery that you spend a little time every so often charging up, so that you have to have fewer battery replacements over time. The battery will last longer, but you do have to charge it. And then finally, who on your team of healthcare providers, usually a movement disorder neurologist, is going to program the device, is going to calibrate the settings and then maintain the settings for you over time. So with that, I think I'm going to stop sharing, and we're going to try to jump into some of the questions that we had submitted for today's talk. So I think just to start off, these systems actually are very, very similar to one another. They're more similar, in my opinion, than they are different. But each of the companies has certain features that some of the other companies don't. And so I wanted to start off by giving a chance to each of the representatives to talk a little bit about features that distinguish your system from the other 2. And we'll start with Abbott, with Yagna. And so one feature that Abbott has that the others currently don't is remote programming. So I'd ask you to talk a little bit about that, and then anything else you think that distinguishes your system.
Yeah, absolutely. Thank you so much, Dr. Mian, for that great introduction into DBS for PD, and for this question. As mentioned, one of the unique features that Abbott offers is the Neurosphere Virtual Clinic technology, which is our remote care technology. It enables physicians to adjust neurostimulation settings remotely. So as Dr. Mian mentioned, once you get the surgery, it still requires programming the device. And there are several steps to that device and then to the device programming. And then once you settle at a stable setting, you might still need tweaks as your symptoms may worsen or your disease progresses. So this technology essentially enables you to remotely connect with your physician so that these settings can be tweaked without you having to go in person. What we have done is that we have created the technology where you as patients can communicate with the doctor via a secure in-app video and receive these stimulation settings in real time, regardless of your location. When we initially launched the virtual clinic platform, we really thought that this would be particularly beneficial for patients who live far away from medical facilities, or they might have difficulty traveling because of their condition. However, we have since discovered that this option is actually valuable to all patients in many different ways. I know a lot of you are snowed in today, so let's say if you had an appointment with your physician today and were not able to travel to the facility, with the help of this kind of technology, you would still have access to care, you would still have access to your neurologist who would be able to tweak these settings remotely. In a recent survey by Dr. Esper et al., they actually showed that about 90% of the patients indicated that that access to telehealth improved access to care regardless of distance. And so our intention really by leveraging remote programming is to enhance patient convenience and improve access to care, which ultimately can improve quality of life. We also think that this kind of technology supports continuous care, but also empowers you as a patient to manage your therapy more effectively and more comfortably. So that's just a little bit of a summary on what our virtual clinic technology brings to the table. In our most recent platform, this technology was further enhanced. And through this remote care technology, we're also able to monitor things like battery status, interrogate the device, remotely to offer more insights to the patient should they have trouble with it. And we can talk a little bit more about that when we talk about our Liberta RC platform as well.
Thank you. Meg, I wonder if you could tell us a little bit about Medtronic's brain sensing and then any other features you wanted to highlight that are different from the other two vendors. You might be muted. There we go.
Sorry, I can save a life, but sometimes I'm technologically challenged on Zoom. Anyhow, I would like to tell you about Medtronic's BrainSense technology. It is unique to Medtronic. We actually invented this technology. And basically what it is that we can see the signals in the brain, the activity in the patient's neurons, and adjust the stimulation to match those signals and watch them dampen. I want you to picture an EKG. We're capturing the electrical activity in the heart, right? So your cardiologist can see what's happening. Well, we're doing the very same thing with the brain. We can actually make a Bluetooth connection with our programming tablets, and I can literally see the activity in your brain in real time. So I can check these spikes. They're called LFPs, which is actually just showing us neuron activity in the brain, and I can correlate it with the patient's symptom in real time in the clinic. For example, if I have a tremorous patient, a Parkinson's, rest tremor like this, I can see those gamma spikes on my tablet. And much like tuning a radio signal, you know how you want to listen to the radio and it's a little, and then you get that clear sound. I can do that very same thing with the brain signals and watch that tremor dampen. I can see those spikes as I fine tune the stimulation to match that symptom and go flat. I can watch the symptoms improve. So it's customization to the greatest degree for patients. So you're not going to overstimulate, you're not going to understimulate. The other feature of this is that it helps with the initial programming. When a patient goes in after surgery, you usually do something called a monopolar review. We're going to check every single little contact or metal band on the lead that's in the brain to see which one provides the best reduction in symptoms without any kind of side effects. So typically this takes quite a long time, but with the BrainSense technology, we can run a quick survey in the office, and within 20, 30 minutes, we can fine tune and know exactly which contact or contacts would get the best results from the stimulation without having to go and check each and every one and take a long time. The other thing about the BrainSense technology is that we can turn on streaming. And so we can set it so that the patient goes home and the device is actually capturing that neuronal or neuron activity in the brain over time, because you don't see your doctor every day. And so when you come back in to see your physician, they can download this information. And let's say the doctor can see that every day about 3 p.m., you start to spike a little bit. It means your symptoms are starting to come back. That tells the physician that perhaps maybe you need to change your medication schedule. So it gives you this picture of the patient outside of the clinic, and you can correlate these waves or signals in the brain with the symptoms, and then fine-tune the device and the stimulation, but also fine-tune when medications are being delivered. Does that make sense? Yes? Okay. I'll talk later on. I know there's another question later on about what's coming in the future, and we'll touch on that a little bit. So that is what sets Medtronic apart, that we have this sensing capability, and we're very proud of it.
Thank you. And Merrick, I was wondering if you could talk a little bit about Boston's independent current control, and then anything else you think helps distinguish your system.
Yeah, absolutely. Thank you, Dr. Mian, and thank you for that great introduction. So at Boston Scientific, we're really a therapy-first company. All of our innovations are really focused on maximizing the outcomes for the patients. So to give you an idea, we were the first company in the world to implant a directional lead. We're the first company in the world to use what's called constant current stimulation, which is kind of a more reproducible stimulation, and the other two companies use that stimulation now as well. But the magic is still within our battery. We have unrivaled ability to apply stimulation in the area of the brain that it needs to go. Many people would agree that I think the best indicator of how well that stimulation is going to do is based on how well that lead is placed. And because of that, the reason for that is there's all these kind of structures around those target areas that will cause some sort of side effect or limit your therapy. So at Boston, we have unrivaled ability to have different types of stimulation types to maximize the outcome. The two ones that I'll highlight that neither of the other companies have, one is called semi-bipolar, and that basically is really good at avoiding side effect and widening therapeutic window. So for some of you that have DBS, you may have experienced in a clinic, slurring of speech or dysarthria, or maybe your muscles start to contract. We've got a unique way to block that from happening, from actually blocking the structure in the brain that causes those side effects. Additionally, there's another type of therapy called hypnotic stimulation that, based on recent work from Emory that was just published at the big neurosurgery conference in the US, does a better job of activating those therapeutic pathways and actually does a worse job of activating those side effect pathways. So these are two options that we have in the bag. And of course, you don't know when you're going to need it. But really, from a development standpoint, we're focused on outcomes, we're focused on therapy, and still today, we're unrivaled in that realm.
Thank you. I wanted to shift gears a little bit, and this time we'll start with Meg at Medtronic. So I'm hoping, and I realize there may be some overlap with the last question, but I'm hoping you could tell us a little bit about why a neurologist or a doctor might choose your system over one of the others. What features or what differences are there that might prompt a neurologist to choose your system?
Confidence, because we are the innovators and the company that actually created deep brain stimulation, and we've been in this space for almost 30 years. So we have lots of experience with DBS. What sets us apart and why a neurologist would choose us, I think, well, our advanced technology with the sensing technology, but also our customer service is unparalleled. And what I think might set us apart is that the ease of programming. It's very easy now with the BrainSense technology for a physician to program a patient and customize the therapy to match that patient's symptomology. Another thing that I think a lot of physicians are thinking about these days is long-term. What's going to happen in the future with my patient? And as you know, 7 out of 10 patients after having a DBS device, for a variety of reasons, will require an MRI. And because Medtronic has the capabilities of patients having not only 3 Tesla MRI, which is the highest magnitude of imaging. Tesla measures the strength of the magnetic field when a patient is getting an MRI. 3 Tesla is the best you can get, and it provides higher quality images in a quicker amount of time. So again, 7 out of 10 patients will require an MRI over time, and that Medtronic offers the ability for patients to have a 3T MRI, not only have the 3T, but the patients do not have to turn their device off. We can put it in what's called MRI mode, because as you know, when you turn the device off, patient symptoms come back. And many times it's very difficult for patients to stay comfortable and stay still in an MRI. So we have the ability for a patient to stay in MRI mode with the device on during an MRI. The other thing that is interesting, talking about MRIs, is that we have just gotten FDA approval for expanded time in the tube. Prior to this, when a patient has a device implanted in the body, because of the possibility of the device heating up, patients would have an MRI and you can only go in for 30 minutes, pull the patient out for 30, put them back in for 30 for that reason. Well, the FDA has just approved our device that a patient can stay in the MRI for a prolonged period of time safely. So our programming capabilities make it easy for a doctor or any kind of clinician who's programming to program the device with ease and really customize it with the sensing capabilities. But moreover, DBS is not the only thing that is going to, treat this patient. The patient's going to have treatments for a variety of other things in their lifetime, and the ability to have advanced MRI is something that a lot of physicians are thinking about when they're choosing a device for their patient.
Thank you. Merrick, I wonder if you could tell us a little bit about why, what features might prompt a neurologist or a treating doctor to choose Boston system?
Yeah, at the end of the day, what we've shown with our data is that we're able to get the same results as monopolar review, as Meg mentioned, in a shorter amount of time. So I'll briefly explain, how we do that. When you go into a programming with the DBS device, what the programmer is doing is they're trying to basically get a sense of where that lead is. So we mentioned monopolar review, turning on a contact, kind of seeing what effects that contact has, both beneficial and side effects, and then turning that off. And what the person is doing is they're building this kind of mental map of, okay, where is the lead, where's the structure, where are the side effects? So that's one method. Another method you could do is do LFPs, listening to those neurons. And we'll do that in the OR with our leads and try to get a sense of where that is. But again, you're trying to build that map of, okay, where is this motor area? Where are these neurons based on where that lead is? At Boston Scientific, we take, I think, a little bit of a more elegant tact at it. We actually show the anatomy on the programmer. We take the MRI scans that are done during the surgery, and we create patient-specific anatomy that is shown to your neurologist. So when they turn on that device, they immediately can put stimulation in the area of your brain that we know gives therapy. And if there are any sort of side effects, they know right away which direction to steer, what kind of tools to use to avoid those side effects. So at the end of the day, when we look at the studies, multiple times, we've shown that we can get at least as good of results as monopolar review. but in much shorter time. I think our average programming time is somewhere between 15 and 20 minutes now. I'll kind of end with a recent study that was published in Nature Parkinson's that showed a group of patients that had already gone through 3 programming sessions without imaging, and then were reprogrammed using, the patient's images. And what they found was that 84% of patients had a self-reported improvement. They had a further reduction in that motor symptom scale of 22%. And a third of those patients were able to reduce their medication by more than half, just by having the images and starting with therapy and then optimizing from there.
Thank you. And then Yagna, same question to you. Are there features that prompt neurologists to choose your system, and tell us a little bit about those?
Yeah, thank you, Dr. Mian, for this question. So I think the number one thing that matters to neurologists is patient care. And fortunately, that's also the number one thing that matters to Abbott. We're really all about creating devices that are simple and easy to use, intuitive, but most importantly, the features that we choose to innovate on and the features that we choose to focus on are really centered on patient care. So with that said, I will say that, Abbott offers a very comprehensive range of devices, which means that we offer options for patients, which I think is a huge benefit for clinicians when they're choosing the right kind of device for their patients. Our portfolio includes both a rechargeable system as well as a primary cell system. I've mentioned the Liberta RC DBS system a few times already, but that was our rechargeable system that was launched earlier this year. It offers the smallest battery with the lowest recharge burden. Additionally, we continue to support our Infinity DBS system, which is our primary cell device, which offers a recharge-free option for patients who actually would prefer that. Both of our systems are outfitted with our Neurosphere Virtual Clinic platform, which I also talked about, which enable neurologists to adjust therapy remotely, enhancing accessibility and convenience for patients. Another feature that we have in our systems that is meant to make programming more systematic and efficient for neurologists is our Informity, feature, which enables clinicians to visualize therapeutic windows and systematically choose programming settings, especially during the monopolar review that we've already spoken about. Ultimately, our clinician programmer app is currently available on iPads, which is a very familiar device to most of our physicians. And we can leverage technical capabilities that already exist on these mobile platforms. So to really summarize, we're really focused on innovative features that are, centered on patient care. Our systems are built on wireless and upgradable architectures, ensuring that as we continue to innovate, our patients can continue to benefit from the latest advancements that we have without additional surgeries. And I really do think that these are the kind of features and these are the kind of options that really matter to physicians, which is why they're more likely to pick the Abbott device. Thank you.
Yagna, you mentioned the clinician programmer, and so that kind of dovetails with our next question, which is, for those who are not familiar, patients are actually provided a programmer with their device that allows them within a limited scope to make changes to the settings, to turn the device off, to put it in MRI mode. And so I was going to start with Merrick, and I was hoping you guys could each show us or tell us a little bit about your system and programmer, just what patients can expect in terms of the device that they're given, how it pairs with their system, and what the interface looks like to the extent that you can show it on a video. Merrick, you might be muted.
Thank you for that. When you get a Boston Scientific system, you'll be given a patient remote. And we're still a little old school. We like to give you something that has tactile buttons. Movement disorder patient, obviously you're going to want, a good feel to the remote. You're going to want to press a button. You're going to feel that button get pressed. So this is our patient remote, very simple, very easy to use. When you look at the screen, you may notice that this green icon basically means that your stimulation is on. If I press the red button, that turns your stimulation off. So easy, obvious kind of interface there. The way to change your program is simply by going into these various menus. So we've got these buttons here, and I'm trying to keep it on the screen, that if you wanted to update your stimulation, it's very obvious. We've got a left body and a right body, And if your clinician gives the ability to turn stimulation up or down, that's the way that you would do it. So the really nice thing about this device is it's very simple. You know, it's pretty much impossible to get lost. You're not going to hurt the system at all. It holds charge for a long, long time. You know, you can charge this thing up and you won't have to recharge it again for 3 months. Again, it's just nice to have that kind of tactile feel. So it may, you know, be a little simpler, but I think there's elegance in simplicity.
Thank you. Yagna for Abbott, could you show us yours?
Yeah, so ours looks like, sorry, I have like blurred backgrounds. So here, I'll
Maybe
just
bring it close to your face so it's the same focus level. Oh, there we go.
there you go. Okay,
Yeah.
so what I was going to say is, so this looks like a cell phone, which is because it is a cell phone. So our patient controller is designed to be intuitive and user-friendly, just like I mentioned for our clinician programmer. This is to ensure that patients can easily manage their therapy. Our patient controller app is currently an iOS app offered with an iPhone SE, as you see on here. But the app is also compatible with other select mobile devices. This feature really allows patients to use their personal devices if they want to control their therapy, making the process more convenient. The app is also designed to be straightforward. We also believe that simplicity is key. So the app has clear instructions, making it easy for patients to navigate through different options. It also displays very prominently therapy status, whether it's on or off. It also allows patients to start, stop, or adjust stimulation as is prescribed by their doctor. Additionally, it allows patients to transition from some of the special modes that we have already talked about, modes like the MRI mode, should they need an MRI, or surgery mode if they need a surgery for something other than neuromodulation, or maybe a replacement surgery. For all of these procedures, we have special modes that they can enter and exit directly out of their patient controller app. And then they can also initiate remote programming from their patient controller as well. So if they have a remote care session already scheduled, they would be able to enable that feature from their cell phone itself. I know I've talked a little bit about our rechargeable system, the Liberta RC. The app for the Liberta RC app also includes alerts and notifications for the device that keep patients informed about status, such as battery levels, recharge status, and then also any alerts that they would need for upcoming maintenance. So all in all, here, I'll see if I can actually show like a screen. So I think you guys can, maybe see it, but you can, this is our Liberta RC app, and you can see kind of the status of both the IPG battery as well as the charger, basically just providing more insights for the patients to better manage their therapies on something as simple and familiar as a cell phone that they might already be using as part of their daily life. So,
thank you. Meg, could you show us Medtronic's device? Might still be muted there, I think. I can't hear you. I don't know if the others can.
Meg, I think you're still on mute.
Apologies, I was
There we
having
go.
a terrible
There we
time.
go.
I actually had to unplug my mouse and do this manually, so my apologies. This is the can you see this? This is the Medtronic patient programmer. It's actually a Samsung 23 cell phone. You can see it's small, it's slim. And like the other patient programmers that were described, we can do a variety of things with this device. Patients can turn their batteries on and off. When would you want to turn your battery off? Let's say you're in the physician's office and they want to run an EKG. Sometimes you might get what we call a cloudy strip if your DBS device is still on while they run it. So with this device, put it in your pocket, take it with you, you make a connection, you turn it off, run the EKG, turn it right back on. It's that simple. Same thing when you're having a surgery. You can check your battery status with this. You can check the battery here. You can check the what your battery level is, the battery in your chest. If you have a non-rechargeable battery, there's a way you can check your battery life, and it tells you how much time you have left before you need to contact Dr. Mian or your neurosurgeon about getting your battery replaced. Or it can tell you, if you have a rechargeable battery, how much charge you have left and when you should be charging your battery. It's that easy. And also, the nice thing is your clinician can put a variety of groups in there, A, B, C, or D, that the patient can toggle through. So let's say you wake up one day, and we know Parkinson's is a transient type of disease where it changes minute by minute. If you wake up one day and you're feeling maybe more stiff or your tremors coming out, you can go into a different programming setting. We call it a group. And it helps with those symptoms a little bit more than maybe your group A. So there's a variety of things you can do with your patient programmer.
Okay. Thank you.
Oh, when it comes to this nifty case, you want to keep it in your case and throw it in your purse.
So we have a few more questions. We only have about 15 minutes left. So I want to make sure we kind of tighten things up so we can get to all the questions, and then hopefully we can get to some audience questions. But we're going to start with Yagna from Abbott. And so if you could just talk a little bit, this was a user submitted or audience submitted question. How does Abbott support issues with the product, like a lost or broken remote, that sort of thing? And you guys may not have very different answers, but this was something that was submitted. So if you could just touch briefly on that.
Yeah, absolutely. So I think I've, mentioned throughout that, we're a very patient-centric company. So we do put patients first. And so with that in mind, our patients and our physicians do have access to dedicated technical support that is trained to support any questions that could arise in terms of any, ongoing product support. For in-person needs, our field team, including our regional therapy development managers, is also highly specialized and capable to support. I'm going to give a shout out to our team in the Rocky Mountain region, which is Cindy Kirkendall, Taylor Humphreys, and Caitlin Fox. They, together they have over 25 years of collective DBS experience, and they're available to support whatever questions might come up, either from the patient side or from the physician side. And like I said, we have a lot of other specialized team members as well who can get pulled in depending on the situation that does arise.
Okay.
Thank you.
Meg, troubleshooting or lost devices, that sort of thing for Medtronic?
Actually, if a patient, what's funny, one of the questions today was, can you show us your recharging unit? And I thought, oh my gosh, what am I going to do if that question comes up? Because I actually had a patient call me yesterday. She was visiting her daughter in St. Louis. She left her recharging unit behind and didn't realize she had done so until she went to charge herself this week. She said, oh no. So her daughter is FedExing it. But meanwhile, I went over and I lent her mine that she can use. But if a patient actually loses one or it's damaged, we have, again, 24/7 support, technical support for our patients. We can provide them with a loaner until we can get another one ordered for them and shipped to them overnight via FedEx. We also, our teams, we take call. So we rotate on call. So you have a Medtronic representative on call 24/7, 365 days of the year available if a patient has a question or there's an issue with a device. We always have somebody available to help.
And Merrick?
Yeah, I think, these are all three very reputable companies. All of them are going to take good care of you as a patient. Similar side from Boston Scientific, we've got great support. There's actually 7 people in the Denver area that work for Boston Scientific. So you've got John, Kylie, Jenna, Glenn, Cameron, Carrie, and Matt Glass. So you've got plenty of support from a local side. And then from the national side, certainly, if a patient loses a remote control or a charger, oftentimes we'll just replace it. And then if it keeps happening, we can have those discussions. But you're in good hands, I think, regardless of what company you choose from a support perspective.
Okay.
Dr. Mian, do you mind if I do a shout out to my team? I'm sorry, I didn't mention their names.
Sure.
Kelly, Taryn, Justin, and Jonna. We have 4 right there in the Denver area.
We heard a little bit about this before, but I'm wondering if you guys can each give us a succinct summary of how your device deals with MRIs. So this is a common diagnostic tool that's needed for patients these days, you know, for orthopedic problems, for strokes, for all sorts of things. And so we'll start with Meg. If you could tell a little bit about, we heard this before, but if you could tell a little bit about
I did
Medtronic's
talk
MR
about it.
compatibility, and then if each of you touch on whether the therapy has to be turned off or not during MRI.
Well, like I said before, MRIs are measured in Tesla units. It has nothing to do with the car. Tesla measures the strength of the magnetic field within the MRI. And a 3T or a 3 Tesla provides faster and higher resolution or quality images. It's the best you can do. Up until recently, patients with DBS devices and other medical devices were only allowed to get a 1.5 Tesla, which is a great picture, but the quality of the picture is not as good as it can be with the 3T. Medtronic has come out with technology that allows a patient to have a 3 Tesla MRI. Patient can keep the device on in MRI mode, so they're not going to worry about turning it off, having their symptoms come back, moving about in the MRI. And also, like I said earlier, with the Medtronic DBS device, we have prolonged MRI periods now. It used to be that a patient had to be in the tube for a shortened period of time for fear of heating up the device. But now with our technology, the FDA has approved the Medtronic device is allowed to have a prolonged MRI. So the patient doesn't have to have 30 minutes on, 30 minutes off, 30 minutes in, and it's a much better patient experience. So we're very, very happy about that.
Thank you, Merrick.
Sure. So our full portfolio is whole body MRI conditional. We actually offer 5 different IPGs, you know, again, going back to that kind of patient first mentality. Whatever you need from a primary cell or rechargeable standpoint, we've got an option for you. They're all MRI conditional for whole body. What we found is that, you know, the need to get a 3T MRI has not been limiting from what you need to see in the imaging. So we're whole body 1.5T. And then from the stem off perspective, Dr. Mian, with our system, you will have to put it in MRI mode, and that will turn the stimulation off. But let's be clear about, you know, what happens when you keep the stimulation on. The stimulation on modes during the MRI is not the same therapy that you're going to be walking around with. That has to be a bipolar mode, which is a different type of stimulation than what you were probably programmed on in clinic. So there's no guarantee that that is going to help you minimize your tremor. But at this point, we are currently turning stimulation off during the MRI for safety reasons.
Okay. And Yagna?
Yeah, so I think when it comes to MRI conditionality, we also have a comprehensive portfolio that is MRI conditional. So both our Infinity DBS system as well as our Liberta RC system, they're both MRI conditional. I've mentioned the special modes that we talked about previously, the surgery mode as well as the MRI mode. So we actually ask that patients, you know, turn on the MRI mode, which is where stimulation isn't off, but stimulation is in a safe mode where their devices are actually going to be protected from the strong magnetic field that they're in while they're getting an MRI. They can enter and exit the mode from their patient controllers. If they do have their clinician alongside, it can also be done through the clinician programmer. And yeah, we are conditional with the most common scanner capability that's out there for clinical scans, and our portfolio is comprehensively MRI conditional.
Okay. Just in the interest of time, we're going to do a show rather than tell. So, you know, one thing that's common for all companies is that the rechargeable battery is a little bit smaller than the non-rechargeable battery. But I'm hoping that each of you could, just for a minute, so folks can see and compare, hold up one of your rechargeable and one of your non-rechargeable batteries, just so people can get a sense of size that we're talking about. So I see Yagna's got 2. So again, you know, almost always, or basically always, the one that requires charging is going to be a bit smaller than the ones that don't. Meg, do you have the Medtronic batteries we can look at? So that's the
Actually, it's the
rechargeable.
thinnest one on the market.
Okay, so folks can get a sense. Unfortunately, like they're different screens, so you can't really see them side by side, but
I put it in the palm of my hand.
okay. Just wanted people to be able to see those. And again, we've just got a few minutes left. So for those who are considering, for patients who are considering a rechargeable battery, meaning one that you charge at home, I'm wondering if we could see the chargers that patients would use, and if you can give us an idea of what is typically, what is typical or what is recommended in terms of the duration and the frequency of charging. And we'll start with Yagna.
Yeah, absolutely. I'll hold up the rechargeable again just so people can see it. So it's about the size of an Oreo cookie. That's the comparison I always like to draw because everyone knows what Oreo cookies look like. And then this is our charger. It is actually a USB-C cord that you get with the charger, which means that if you, I know one of the questions was what happens if you lose a component or something. So if you lose your USB-C charger cord, you can literally buy it from any gas station. The IPG typically goes, subclavically, so in the chest area, and then this would go kind of on top of it. It does have an expanded field of coverage, which means that it doesn't have to be directly on the device in order to actually initiate charging. But the more optimally it is placed, the faster the device will charge. In terms of how frequently you have to charge, at nominal settings, we actually expect the recharge frequency to be about once every 37 days. However, that's we're all people of habits. So to build habits, the clinician programmer will also offer an estimate of a weekly charge duration. So it could be something as little as you have to charge 20 minutes weekly just to top it up. And you could do it, while watching your favorite show, while listening to your podcast, while doing your dishes. So we actually do provide an ergonomic sort of counterweight apparel, as well as sort of an across the body apparel for a hands-free charging experience as well. But ultimately, the patient can decide, do they want to charge it monthly? Do they want to charge it weekly? What is really best practice for them? And the goal is to offer flexibility to navigate through the therapy. I will also say that if the device does discharge completely, it can be recharged intuitively. So it's as simple as just kind of placing the charger back on the device. And once the battery reaches about 5%, which takes about 5 minutes, stimulation can be turned on and the device can be continued to charge. So in order for you to recharge your device, the stimulation doesn't actually have to be off. You can charge your device while the stimulation is on. If the device is completely recharged, it takes about 5 minutes to hit 5%. And then from that point on, you can have your stim on while you're recharging. So minimal interruption to your therapy.
Meg, could you show us Medtronic's charger?
Like I said earlier,
Oh, that's right. Sorry.
I lent it to one of my patients. I'll get it back as soon as hers is FedEx from her daughter. But it's similar to what Yagna just described. There is a charging disc. Charger is in a small disc, and it sits on a charging platter, much like you charge your cell phone. And then when you're ready to charge your battery, you wear a sleeve around your neck that has a pocket, and you put the charger in the pocket. You make a connection over your battery, it turns green and it beeps, and then you sit and read a book or you watch a movie. Now, it's very hard to say patients are going to charge once a week for X amount of time or once a month for X amount of time, because we all know that settings are extremely variable. So if you have a tremorous patient with high settings, they're going to burn through their battery quicker than somebody that just has some slowness and stiffness and has very small minimal stimulation. So that's hard to gauge. However, I would say on average, patients likely will do it once a week for perhaps 20 minutes. Also, patients can top it off every day if they're a creature of habit like I am. I tell patients, if you're a reader, if you read a book every night before you go to bed and you feel like incorporating that into your daily routine, It's not going to harm your battery in any way by topping it off on a daily basis. The other thing about the Medtronic Percept rechargeable battery is that it lasts for a full 15 years. And what I mean by that is it's made of a new component called lithium titanate. We all have cell phones, right, with lithium batteries. And we know that probably after about 2 years, the more you charge the battery, the more the battery starts to fade. And what I mean by that is the battery takes longer to charge and it loses its charge quicker. So you're having to charge your battery more frequently and for a longer period of time. With this lithium titanate technology, the battery has no fade. So it's as strong as it was when it came out of the box 15 years later. So that is a really interesting technology that we have created right in our own Medtronic labs. The other thing about this battery is the old versions. It used to be 3 strikes and you're out. If you let the battery go down to 0 and you did that 3 times, the battery would just shut off for good. With this one, that doesn't happen anymore. We have something called rapid recharge. So where if you let your battery go down to 0, it takes 50 minutes for you to charge it from 0 to 100 in 50 minutes. So that's pretty good because life gets in the way. People get busy, they forget to charge, and then, uh-oh, my symptoms are back. Oh no, I have to sit. It takes about 50 minutes. So we're really happy and very pleased about the technology, especially with the lithium titanate.
Merrick?
Sure. So we've actually got the smallest charger on the market. I'll put it in the palm of my hand just so you can see there. Most of our patients will recharge about 15 to 30 minutes a week, but we proudly publish that we have a 200 milliamp hour battery. So what that means, if you want to go 30 days without recharging your battery, you can do that. You by no means need to have daily charging or charging every few days. You can even go 10 to 12 times a year if that's really something that you think fits into your schedule. From a longevity standpoint, our rechargeable battery is warranted for 15 years. It won't turn off after 15 years. And we've got studies that show it has at least 90% capacity still at that 90-year mark. So from the frequency of recharging, that's not really going to make a big difference on how long you're going to recharge, how frequent you're going to have to recharge, even at that 15-year mark. And again, that's because we put patients first, and we want you to give a device that can last a lifetime if that's what you need.
Thank you. I know Jody probably showed up because we're at time here. We have one more quick question. I'm going to ask you guys to each limit to just a minute or so, but just basically closing remarks for each company. Is there anything you'd like to highlight that we really haven't touched on in detail about your system? And we'll start with Meg from Medtronic.
Like I said earlier, Medtronic is the innovator and the originator of DBS therapy. So we have over 30 years in this space, and we're constantly coming out with new products, new ideas, new innovations. Actually, what's exciting is that in 2021, Medtronic launched the first of its kind adaptive deep brain stimulation trial for Parkinson's disease. And I can't speak much about it because it's still being reviewed by the FDA. But what I can say that coming out in the future, adaptive DBS allows the system to automatically adjust neurostimulations levels up and down according to the brain signals in your brain, capturing those neurons, those LFPs. The results of that study, however, are under the review of the FDA right now, and we're anticipating that the FDA is going to approve the use of adaptive DBS therapy in the near future. So look for announcements about that.
Thank you. Yagna?
Oh, one more thing, Dr. Mian, I forgot to say. Our technology allows for software upgrades. So if we do have new technology that comes out in the future, we don't have to replace the battery. We can just do simple software upgrades.
Yagna?
Thanks, Dr. Mian, and thank you to all the panelists for being part of this webinar with me today. I think in closing, I will say, so our Liberta RC battery also does not have an end of life, so it's estimated to continue working seamlessly for forever. But in terms of kind of just, closing remarks, I will say that we are focused on patient-centric innovation, and we're really committed to improving care access. Our Infinity and Liberta RC systems demonstrate how we have optimized for the patient experience while continuing to advance on capabilities like enhanced connectivity and remote programming. Our systems are upgradable, so any future innovations that we commercialize will be available to patients regardless. And all of our systems have been capable of that, including our Infinity systems and now our Liberta RC systems. So thank you again for the opportunity to speak to the patients today. And I'm really proud of the patient-centric portfolio that we have. And if anyone has any questions, I know we're kind of at the end of the webinar, but if anyone has any questions, please feel free to reach out to our field team that I've already mentioned before, Cindy, Taylor, as well as Caitlin. They're kind of our boots on ground there. And so I wanted to thank them also for the wonderful work that they're doing for the community out there. Thank you.
Thank you. And Merrick.
Absolutely. So hopefully I've kind of shown you how focused we are on patient comfort and outcomes. There's a reason when you look at the new implants every year in the world, Boston Scientific is #1. What I will speak to from the future standpoint is we're continuing to do that. From the patient side, I can say that we do see value in things like remote monitoring and remote programming. The good news is our devices don't need any upgrade to do that. Once those therapies are made, it's just a simple change on the physician programmer, no upgrades needed on your hardware. Additionally, we just had approved in automatic programming and software. And what that does is it further increases the efficiency and improves the outcomes of the programming. It actually looks at your anatomy, and then based on what your clinician wants to do, it will shape a custom stimulation field to your anatomy. So a patient-specific custom stimulation field. And we presented some data on this at the biggest neurology conference in the world that happened a couple months ago. And what we see from a small number of patients is that those outcomes look great. And then when we talk about efficiency, getting you result quickly that lasts, in those 8 patients, that's also occurring. So thank you for taking the time. Thank you for looking at it. If you like any other information, dbsandme.com is a great spot, and check out our webinar schedule. There's a lot of good information there.
Thank you, guys. I am going to quickly go through just a couple slides here at the end to wrap up. You guys see that? Okay. So, I think it's helpful as somebody who uses all 3 of these systems just to take a step back and remind everyone watching at home, all 3 of these vendors have excellent products that are safe and effective. And, I think sometimes patients agonize over which one to choose. The reality is that you're going to get benefit from any one of these devices if you select it. And I think, in my opinion, the benefit you do experience from DBS matters much more in terms of the job your surgeon does in terms of placing the lead accurately, and the job your neurologist does in terms of programming the device than the device itself. So I don't want patients to stress about the device choice too much. I mean, the therapies are all good. They all work. These teams are excellent in all cases, and please do not lose sleep over that decision. I think it's important to reach out to your neurologist or whoever is going to be programming the device for you and ask their opinion. Do they have a preference? Do they have more comfort with one device or another? I'll sometimes make the analogy to cars. So, you can buy the coolest, fanciest car in the world, but if you don't live within 500 miles of a service center and there's nobody to help with using that car, you're just not going to get the best use out of it, and maybe it's not the best car for you. And so the input of the team that's taking care of you is really important. Ask for their input, ask what they prefer. Generally speaking, this is always the patient's decision, but lean on those who are working with you and taking care of you to help with that decision. I'm going to make a quick plug again for my website. I have a variety of materials that describe some of the issues we've gone over today. Not so much the nitty-gritty of the different companies' products, but there are things like a DBS guide for patients that I give all my patients or ask them to print out before surgery and read just a few pages. And with that, we're going to wrap up. I know we've received a number of questions. I'm going to leave it to Jody as to whether we have time to address some of those, but happy to get through some of them if we think we have a few minutes.
Yeah, I was going to see if the panelists had about 10 or 15 more minutes that they could spend on questions. And if you don't, I have screen grabs of all of the questions and I can get responses and send them out to the group. So it is completely up to you if you've got a few extra minutes here.
I'm happy to stay as long
I
as you.
do.
Okay,
Try to do it in
wonderful.
5 minutes. Let's try for that.
All right, let's try to do it in 5 minutes. All right, so a couple of the questions that we have, and we did have a couple of raised hands, I know. So if you were one of those and you have not typed your question in the chat box, if you can please do so. And then that way, the questions we don't get to, we can definitely find answers to you and get them over to you. So the first question that we had was talking about worsening of gait post-operation, freezing of gait. And is that a typical complication? Is that something that DBS can help? What is the response on that question?
So I think rather than have the panelists, this is not
Yeah.
going to be a question that's specific to any device.
Yeah.
So freezing of gait is a challenge in Parkinson's disease. Certainly there are reported instances of it getting better or getting worse after DBS. In my experience, there's not often a consistent response of freezing. And I would say that is not really dependent on the type of device that you choose, the vendor that you choose.
And then I believe that the question for the MRI was answered already with Boston Scientific's response. There was a comment here specifically for the Medtronic sensing function. Can the patient turn it on to record and then email that to their neurologist?
The physician sets it on record. And then when the patient comes to the physician's office, they just download the data right there in the office. But
Right.
no, it's not email capable because it's HIPAA compliance. You have to be very careful with that.
Perfect. Okay. And then another question that would apply to the batteries. If you're wanting to change your non-rechargeable battery to a rechargeable battery, are there inherent complications to contend with? Or is that a simple surgery?
Yeah, I can take that on. I think the answer is basically the same for every company, which is that your extensions, the leads, the wires that connect to the wires that are in the brain that connect to the battery can be inserted into either a rechargeable or a non-rechargeable in all companies' cases. And so if a patient needs to convert one way or another, that's not a problem. It's about a 20-minute surgery to swap out the battery in any of those cases.
Perfect. And that kind of leads to the next question, Dr. Mian, which probably is the same as well. Are the wires, the leads, and the probes the same? Can they be used interchangeably if you switch to different products, different devices?
Yeah, so each company's leads are proprietary. They're a little bit different. They're very similar, but it's imagine trying to plug in a USB-C versus a micro USB versus a lightning cord. You need different adapters. And so while some companies do have adapters, in the interest of time, we're not going to get into which ones and what that looks like. While some companies do have adapters that allow you to switch one company's leads and be compatible with a different company's batteries, in general, as a surgeon, this is my humble opinion, that's something I try to discourage in patients because creating these mixed systems can complicate things about your care. It can complicate getting MRIs. Maybe that's not the most popular answer for the panelists, but in general, I try to discourage patients from mixing and matching components from different systems. It just makes everybody's life more complicated. And in my opinion, it doesn't change. Your leads are positioned where they are. The programmers are a little bit different. But I, generally speaking, don't encourage patients to mix and match systems from different manufacturers.
Okay, thank you. And with that, we very quickly answered all of the questions. So that's wonderful. I really want to thank you, Dr. Mian, for moderating this panel and working hard to come up with good questions and helping those in the Parkinson's community make some tough decisions on which device they might want to use. Yagna, Merrick, and Meg, I very much appreciate your time and honesty and willingness to share with the community. And this recording will be out on our YouTube channel And for all of those of you who registered, you will also receive a link to that recording. So once it's up and running. But that is it for today, and I appreciate everybody's time and have a wonderful rest of your week.
Thank you so much, Jody. It's
Thank
been a
you all.
pleasure.
Good, thank you.
Thank you, Jody. Thank you, Dr. Mian, and I hope you all get to stay warm since it's snowing
Yes.
out there.
All right. Have a good
Thanks,
day,
everyone.
guys.
All
Have a
right,
nice day.
thanks, everybody. Bye.